Welcome to applying latest guidelines and recommendations to initiate biologic therapy and control moderate to severe asthma symptoms. This presentation is in collaboration with the Global Education Group with Asthma and Allergy Foundation of America and broadcast simultaneously through Immunology Live and Res Insights Live. My name is Dr. Reynolds Panettiere. I'm a professor of medicine at the Robert Wood Johnson Medical School. Today's session is interactive. This should be a lot of fun. Everyone, we're really reaching out to have you answer some of the questions, allowing us to take questions in real time throughout this presentation. And we encourage you to enter questions at any time in the box below. I'd now like to introduce my co-presenter and a good friend, Dr. Nick Hanaya, Professor of Medicine at Baylor College of Medicine. Thank you. Thank you, Nick, for joining me today. And let's get started. So these are our faculty disclosures, mine above and Nick's below. Neither of these, by the way, are going to impact on our presentation. So what are we trying to learn? The learning objectives are to describe the role of T2 inflammation in asthma pathophysiology, identify patients with uncontrolled, moderate to severe asthma who could benefit from the addition of a biologic agent. We're going to summarize safety, efficacy, and long-term data for biologics used to manage patients with moderate to severe asthma and comorbid T2 inflammatory conditions, and initiate a biologic agent for a patient with uncontrolled moderate to severe asthma based on current evidence for clinical trials, real-world experience, up-to-date guidelines, and recommendations. So let's get started. Defining uncontrolled moderate severe asthma. How confident are you in your ability to recognize a patient with moderate to severe asthma who is uncontrolled? A, extremely confident, B, very confident, C, somewhat confident, D, not very confident, E, not at all confident. So vote your conscience on this one. Give this a moment. Okay. The most common answer is C. So we have opportunity to improve on the knowledge and hopefully address exactly the issues to date in the use of biologics. A survey on practice patterns in moderate to severe asthma is shown here. We had an N of 30. There were 83% MDs and DOs. 50% managed up to 25 patients with moderate to severe asthma per month. Roughly 70% of the respondents said that up to 20% of their patients are currently on oral corticosteroids. That's a substantial burden, an OCS burden, which my colleague is going to go over quite extensively. On the specialty side, you can see it broken out by pulmonary allergy and immunology, and in the practice setting, academic, but the majority of the people answering this poll were in private practice. On the other side, the specialty most represented was A&I. So a survey on practice patterns in moderate to severe asthma is shown here. And now we're focusing on assessment and diagnosis. What methods do you use to assess your patient's asthma control? And you can see here, percentages on the ordinate, the y-axis, gene and need for OCS, asthma control test, validated questionnaire other than ACT, my own questionnaire, and patient's record of symptoms. Surprisingly, only 50% 50% of respondents actually use the ACT test. Now, if we couple that with other than ACT tests, and there's a variety out there, you're well familiar, you're up to about 70% of people who do use objective measures to characterize patient-reported outcomes. So let's now focus on asthma management guidelines. This is the 2020 focused update. This was published in December 3rd, 2020 by NIH, and it's really a comprehensive approach to the management of asthma. So how do we define moderate to severe asthma? Well, using the ATS-ERS guidelines, it's asthma in patients aged greater than or equal to 6 that would be uncontrolled if not for high-dose ICS plus second controller or systemic steroids for greater than or equal to 50% of the previous year. Asthma that remains uncontrolled despite these therapies. So what are we talking about? We talk about moderate to severe asthma. These are people we have to use a lot of medicine, can't taper it down, and in some instances remain uncontrolled. It is important, though, to confirm that the uncontrolled asthma symptoms are not due to other confounding factors. Not all that wheezes is asthma. So what are we talking about? What slice of the pie is the prevalence of severe asthma? Well, that encompasses or comprises about 25 million Americans have asthma. And of the severe group, that would be anywhere from about 2.5 to 1.5 million patients. So the severe asthma group is a substantial slice of the pie, and that pie accounts for a large amount of the morbidity and mortality associated with asthma. 25 million Americans have asthma, about 5 to 10% severe asthma. So let me pause here because it's really important to hear a patient talk about their story, the impact of uncontrolled moderate to severe asthma on a patient's quality of life.
So before I was diagnosed with asthma, it just kind of was, I would get, anytime I got a cold or a virus, it just lasted and lingered for a long time. And if we were hiking or something, I would just like get out of breath really easily, like before anyone else in my family. And I got diagnosed with asthma sometime in my like early teens. And it was just like mild. I didn't need to be on any control or medication. I just occasionally took albuterol. But as I got older, it got a lot worse to the point where it actually ended my running career, to the point I just couldn't compete at the level that I was used to competing at anymore. And so I had to pull back from running to try to figure out what changed and how to fix it. I was really struggling with the kind of life impacts of having severe asthma, and also just kind of being a 20-something-year-old that was dealing with chronic illness that impacted my life in a significant way, whereas most, if not all of my peers didn't have that kind of thing. It was something so simple as, oh, like, hey, let's go out tonight and we can crash at so-and-so's place, was not so simple, because I had to be like, okay, well, I can do that, but I have to remember to pack all my meds so that I have things. I have to make sure I have an inhaler everywhere I go. I have to make sure that if it's winter, I'm not leaving them in the car where they're going to freeze. I have to bring them with me. And so it was just a lot kind of emotionally. Before I got on a biologic, the treatments I was on for my asthma significantly impacted my quality of life. I have pretty low bone density for someone that's in their late 20s, due to all the years of steroids and all the very many courses of steroids. I also had issues with recurrent esophageal thrush, just from a combo of all the steroids and just having everything be suppressed all the time, which we figured out was not related to oral care, because I was religious about the rinsing and the spacers and all the things, but the dry powder inhalers had a lot of the combo meds. So we figured out that was a dry powder inhaler problem, but it was just, it affected my diet. It affected like so many things. I actually even ended up breaking my back a couple years ago because of my low bone density. Like I shouldn't have, but I did. So thankfully, I'm off of many of the things that have the treatments that have impacted my quality of life, but it certainly is not, I can't do anything without thinking of my asthma first and making sure I've got the things I need.
Wow, that was an impactful story by Kelsey, but not different than many of the patients you care for in your practice. The burdens of moderate to severe asthma from a patient's perspective are shown here. These are little excerpts. I've struggled with depression personally, and I've been so sick that I probably struggle with it every day now. On some occasions, the mind's there, but the body can't keep up. Most housework, I can too. Can't vacuum, can't do the bathroom, anything like that. I've lost in every facet of my life. When my kids were young, I couldn't play with them. These are just excerpts from the many, many patients with severe asthma that are so impacted. Even though severe asthma represents only 5 to 10%, remember up to 2.5 million Americans, they seriously are affected and are contributing disproportionately to morbidity and mortality. Now, moderate to severe asthma control often can be overestimated. The Chronicle study is a real-world evidence study conducted in 398 adults with severe asthma, 71% on biologics, 13% on maintenance OCS, oral corticosteroids, and 18% on high-dose ICS controller. 60% of the physician's characterization of the patient was controlled, but the patient's ACT results show 53% were controlled and were found not to be well controlled by ACT. So consider more routine use of patient-reported measures, such as the ACT, to inform assessment of control. In that questionnaire that you all answered, about 50% used ACT. So we have room to do better in the measurement, objective measurement of patient-reported outcomes. So what about OCS? Well, the pitfalls of chronic OCS use in moderate to severe asthma is demonstrated here. 32 to 45% of patients with severe asthma require frequent and often daily oral steroids. 93% of an asthma registry patients with severe asthma had greater than or equal to one condition linked to OCS burden, and that's type 2 diabetes, osteoporosis, cataracts, weight gain, depression, hypertension, and so forth. So that is a stunning number of comorbidities associated with oral steroids. Management strategies that minimize the use of OCS, and remember, that's within the context of exacerbations, can decrease adverse effects. So what tools can we use to really get a handle on measurements of patient-reported outcomes? Well, you heard about the ACT test. There's the asthma therapy assessment questionnaire and the asthma control questionnaire. All three of these are very powerful tools that could be deployed. So now let's move on to some pathophysiological mechanisms, which I find incredibly exciting now. This is the need to know what's hot. And we're talking about the underlying pathobiologic mechanisms of moderate to severe asthma, the dynamic epithelium. Well, we know that clinical heterogeneity exists in moderate to severe asthma, and that's shown here. It's depicted in this color schema, not only for diversity in ethnic and racial diversity, but also with regard to early, late onset atopic, low FEV1, OCS resistant. There are many pathways by which asthma can occur, and frankly, every patient is a snowflake. They're unique when it comes to their asthma. We can't just clump and lump people together. Patients with refractory asthma represent differential phenotypes, endotypes that don't or who may respond to conventional therapy. So let's take a look in this cartoon at high T2 and low T2 mechanisms of inducing airway hyperresponsiveness and airway hyperresponsiveness. On the left side, you see T2 high. This is typically driven by allergens. The allergens can affect the epithelium, or the epithelium can be injured by viruses, and that's associated with alarmin secretion, TSLP, IL-33, and IL-25. That's also detected by dendritic cells, that is the allergen component, generating high T2 inflammatory cytokines. Which are those? Well, they're IL-13, IL-4, and IL-5. Of course, IL-5, incredibly important in eosinophil trafficking and survival, while IL-4 and IL-13 can modulate B cell function, can also modulate directly structural cell function, like the epithelium itself or the smooth muscle or myofibroblasts. The IL-5 can, as mentioned, promote survival of the eosinophil as well as the basophil. The TSLP, IL-33, and 25 can directly act on structural cells or could act on ILC2 cells as well as dendritic cells. Now, in the low T2 space, not driven by the traditional IL-13, 4, and 5 T2 high inflammatory mediators, we have a different set of modulators, but the alarmins are still quite important. They can activate Th17 cells, can affect neutrophil function and chemotaxis. IL-6 and TGF-beta can also be important mediators in the low T2 space, as well as the interferons and TNF. So you can see that there's a continuum between high T2 and low T2 space. Now, there's other pathways implicated in the T2 low space. We talked about the neutrophil as being incredibly important, but so is the macrophage, as well as the epithelial cell directly acting as an immune organ, modulating trafficking leukocytes. Key cytokines in the low T2 space, IL-1 beta, IL-8, of course, chemotactic factor for neutrophils, IL-17, and TNF. Other pathways, much of this could be modulated by obesity, is those that affect the IL-6 mediated airway inflammation. Here shown how IL-6 can be secreted through epithelial cells. They also is secreted, by the way, by structural cells, submucosal fibroblasts, and smooth muscle. And IL-6 high asthma is characterized by elevated plasma IL-6. And as I mentioned, this is also seen in the systemic disorder of metabolic dysfunction and obesity. So we are uncovering new mechanisms of low T2. Now, asthma endotypes are shown here. The high T2, we talked about those cytokines being IL-4, IL-5, and IL-13 produced by Th2 T cell subsets as well as ILC2. And biomarkers traditionally are eosinophils in the blood, elevated IgE and FeNO, so atopic and eosinophilic asthma. On the low T2 inflammatory response, again, we talk about IL-1, IL-6, IL-8, IL-17, and TNF. Now, unfortunately, in this space, there are no easy biomarkers to measure. So the whole point here is we have T2 high, we have 3 very robust biomarkers, T2 low, no biomarkers. The way we identify that is by a paucity of high T2 biomarkers. Not a perfect case definition. But the common clinical features of asthma, T2 high and T2 low, are summarized here. The later onset seemingly is going to be the T2 low patients. They often have a bit less obstruction, less responsive. Allergen, not a particular prominent trigger. Exhaled NO is typically low, no eosinophils, maybe neutrophils are present, and the low T2 are notoriously less steroid sensitive. Now, what are the features of high T2? Well, you know this. Early in childhood, most of these patients are high T2 allergen, have a lot of variability in their airflow, are more responsive to bronchodilators, have greater responsiveness to inhaled as well as oral corticosteroids. They could be eosinophilic or high T2 mediated high nitric oxide, exhaled nitric oxide. So with that, I'd like to pass the baton, the virtual baton, on to my colleague. Dr. Hananea will now talk about optimizing use of biologic agents for patients with uncontrolled moderate to severe asthma. Nick, take it away.
Thanks, Ray, for setting the stage for my part of the talk. And we're going to take you for a trip on what we know about biologic agents for asthma and what we've learned and continue to learn. Actually, this is an evolving field. But first, let's shed light on Kelsey's story. It's very interesting what this young lady went through. But let's listen to some of the more promising part of her story, and then we'll continue.
It took probably almost 10 years to get it like actually managed appropriately or begin to be managed appropriately. I think some of the main barriers I faced in terms of finding the right treatments for me had to do with just not having typical severe asthma. I didn't have high IgEs, I didn't have high eosinophils, but we couldn't get things under control or keep things under control without oral steroids. And so it took a while for there to be a product out that worked for that. Thankfully, there is now, and that's made a huge difference. But just I think not having typical asthma was the biggest barrier. I wish my early clinicians knew how frustrated I was. Part of that's on me because I didn't always tell them, but because I didn't think I could. But now I wish I probably will now. Sorry. I wish my doctor now knew how much of a gift it's been to like find him in this journey, because not only did he give me like so much of my life back, he also just made me feel heard and treated me like I was part of the team, not just the patient that the team was helping. But I mean, I've been able to do things that I didn't think I was ever going to be able to do again. There was like a point in time where I kind of was resigned to the fact that I was probably just at some point going to die from a life-threatening asthma attack, and there was only so much I could do. And my doctor now has taken that fear away, and that's been a huge gift.
So the story of Kelsey is not unique. As you heard from Dr. Panettiere, we see this on and on every day, especially if you're an asthma specialist, allergist, pulmonologist, but also many of you are maybe primary care and you may see patients with moderate severe asthma who already been started on biologics. The story about biologic is evolving, as I mentioned earlier, but starting a biologic is really it tends to be the last resort after we go through an intensive checklist of things. As you see from this inverted pyramid, we start by diagnosing asthma, confirming the diagnosis. Anyone with uncontrolled asthma needs to have a confirmed diagnosis because many mimickers are there that can mimic asthma. We should actually treat and manage comorbidities and triggers. We also want to make sure we optimize the inhaler therapy that patients are often on, make sure they're using the inhaler correctly, but also using it on a regular basis, and adherence has to be confirmed. Then after that, patients who continue to have symptoms despite all this are named and require high-dose inhaled steroid plus another long-acting bronchodilator, have severe asthma, and can be phenotyped for possible biologic therapy. Now, when it comes to biologics, actually, this is a table of what biologics have been approved in the United States. As you see, we will go through some of these groups in more details. But you can see that we have 6 biologics approved, and some of them are target different cytokines. Anti-IgE, we'll talk about that in a second, is approved mainly for allergic asthma in kids 6 and above, and adults given once a month or twice a month based on IgE level and weight. It's also approved in urticaria and nasal polyposis. The anti-IL-5 agents, either targeting the cytokine, interleukin-5, or the receptor for the cytokine, interleukin-5 receptor. These are 3 of them. 2 are given subcutaneously every 4 weeks. Every 4 weeks or every 8 weeks, depending on which one. Benralizumab is every 8 weeks. And 1 of them is given IV infusion. And as you see, these agents are approved for eosinophilic asthma mainly. And then dupilumab targets IL-4 receptor. We'll talk more about it in a minute, and I'll show you some data. It is approved for steroid-dependent asthma, eosinophilic asthma, as well as has approval for atopic dermatitis and rhinosinusitis with nasal polyps. And it's given every 2 weeks by subcutaneous injection in children 6 and above, and of course in adults. And then the last one is tezepelumab, which targets TSLP, which is one of these alarmins that is given every 4 weeks in patients with asthma in general. So question is, for a clinician like myself, how do I make a decision which biologic to use? Of course, we look at clinical outcomes in clinical trials, but also now in real life studies that are more and more are being published and done. We look at biomarkers to have an idea which biologic to use, depending on the T2 inflammatory background of the patient. We look at comorbidities, which make a major decision for us, because comorbidities are important to treat, and some of them can target these comorbidities. We look at safety profile, and more important is we look at the patient. A shared decision-making approach is very important. We'll talk about these things in the next few slides. So let me take you for a quick tour in what we know about these biologics, at least at this point, that we can share with you. Targeting IgE, as we know, immunoglobulin E is an important mediator of allergic inflammation, and IgE is usually circulating in high levels in patients with allergic asthma. Targeting IgE and preventing this IgE from tagging on the Fc receptors on inflammatory cells is important. It may have an effect also on the dendritic cells and may have an effect on viral clearance. But in general, omalizumab, which has been approved now more than 18 years, is approved for allergic asthma. And indeed, in those patients with allergic asthma, giving omalizumab based on IgE level and weight, either every 2 weeks or every 4 weeks, depending on the IgE level and weight, has been shown to, as you see here from this meta-analysis, to reduce exacerbation and hospital admission, and also reduce the need for high-dose inhaled corticosteroids. So it's an important biologic that for many years was the only biologic approved in the United States. Later on, drugs that target interleukin-5, you heard from Dr. Panettiere very nicely how he illustrated that interleukin-5 is an important cytokine in bringing in the eosinophils from the bone marrow, maturating it, differentiating them, and making them happy, basically. And targeting IL-5 can be done either by targeting the cytokines with mepolizumab, praslizumab, these are 2 biologics approved, or targeting its receptor with a drug called benralizumab. And of course, these targeting IL-5 is very important in a subtype of type 2 high asthma, and these are patients with eosinophilic asthma. So for these agents to work, patients have to demonstrate eosinophilic inflammation, usually reflected on by high blood eosinophils, usually more than 300 cells per cubic liter in the blood. But also, these agents may work in patients with high blood eosinophils who are dependent on oral steroids. So what's the evidence that mepolizumab or benralizumab work? There are several studies. I'll share with you some of them because of the time. These are the pivotal study that got mepolizumab approved in the United States. And as you see here, mepolizumab given either intravenously or subcutaneously once a month, every 4 weeks, was superior to placebo in reducing exacerbation in patients with severe asthma who have eosinophilic phenotype, but also improved lung function. And of course, the sub-Q formulation is the one that is now approved in the United States. Very similarly, benralizumab, which is an anti-IL-5 receptor, shown to reduce exacerbation in eosinophilic asthma if given every 4 weeks or every 8 weeks, and now it's approved for giving it every 4 weeks for 3 months, and then every 8 weeks later on, and also improvement in lung function. So these drugs work best in patients with high blood eosinophils at baseline who have severe disease. But these agents also have been shown to have a very important effect in reducing oral corticosteroid in patients with eosinophilic asthma. This is a study on mepolizumab, the Syria study, where it was a 6-month study where they looked at reduction in oral steroid with mepolizumab injection versus placebo. And not only that, it reduced exacerbation, but also reduced need for oral steroids by 50% compared to placebo injections in this group of patients. And very similarly, benralizumab has been shown also to reduce oral steroid in patients who are dependent on oral steroids, who have eosinophilic asthma, compared to placebo. So I think one of the very important benefits from anti-IL-5 agents in patients with eosinophilic asthma is the fact that they have a significant effect in reducing oral steroid need in that population and reducing exacerbation. A third biologic that works through a different mechanism is dupilumab. This is a drug that works on targeting interleukin-4 receptor, which is a very important common receptor for 2 cytokines. One is interleukin-4, and the second one is interleukin-13. And as you see, these are very important cytokines in T2 inflammation. In patients with T2 high inflammation, interleukin-4 is a very important cytokine in producing IgE, and targeting IL-4 will reduce the production of IgE, but also will reduce the recruitment of inflammatory cells into the airway. Interleukin-13 is a pleiotropic cytokine, has effect on mucus hypersecretion, airway hyperresponsiveness, airway remodeling, and also effect on smooth muscles, as well as effect on recruitment of inflammatory cells, particularly eosinophils, to the airway. And what's the role of dupilumab? Very similar to other biologics, this drug was tested in large clinical trials. This is the largest one, called the Quest study, where they looked at patients with moderate severe asthma who are uncontrolled despite adequate inhaled corticosteroids and long-acting bronchodilator therapy. And they showed over the 1-year study a reduction in exacerbation, a significant reduction in 2 doses that they tested, the 200 milligram is given every 2 weeks, or 300 milligram. But one of the very important characteristics of dupilumab is the improvement in lung function, which is quite significant within 2 weeks of treatment. When they looked at subgroup of patients, the groups of patients that benefit most from patients that benefit most from dupilumab are those patients who have high blood eosinophils and high FeNO, meaning high T2 signal. Those are patients who would benefit most from a drug like dupilumab because they reduce exacerbation more than patients who do not have high blood eosinophil or high FeNO. Similar to what we have seen with anti-IL-5, dupilumab has been also shown to reduce oral steroid need in patients who are oral steroid dependent. And this actually occurred despite even if in patients with low blood eosinophils. So there's really no attachment for using this drug in oral steroid dependent asthmatics. It's actually the only biologic approved for oral steroid dependent asthma in the United States right now. Reduction in both the dose, but also in some patients, elimination of oral steroid need in this 6-month study called Venture. Now, there are some now long-term sequelae or follow-up on these clinical trials showing persistent of effect in reducing exacerbation after the 12 months of the study. The data from Quest, which is a 12-month study, was followed by these patients who were given open-label dupilumab, who were on placebo, and then followed up to 96 weeks, showing significant reduction in exacerbation that persists over the 96 weeks follow-up. Similarly, effect has been shown in the improvement in lung function after the 1 year of the trial, suggesting that there is a long-term effect now on reduction in exacerbation and improvement in lung function up to 96 weeks of follow-up. And there are now longer-term real-world studies showing persistent effect on reduction in oral steroid in patients who are oral steroid dependent. Now, the last biologic that was approved is called tezepelumab. And what tezepelumab is, it blocks what we call TSLP, which is the thymic stromal lymphopoietin. It's a cytokine, or is one of the three alarmins that we have. Alarmins are cytokines that are important, that are epithelial generated, and they play a role in both allergic and also non-T2 asthma. So they work in both T2 high and non-T2 high asthma. And blocking TSLP has been shown to improve airway hyperresponsiveness or reduce airway hyperresponsiveness in patients with allergic asthma, reduces response to allergens. Now, large clinical trials now have been published, the last one of which was the Navigator study, which got this drug approved in the United States. And this included a large number of patients with moderate severe asthma with history of exacerbation, showing reduction in exacerbation given this drug once a month in different subgroup of patients, including both high blood eosinophil at baseline, low blood eosinophil at baseline, but also patients with high FeNO or low FeNO. And indeed, when they looked at lung function improvement was seen within 2 weeks also with tezepelumab versus placebo in this population, and the side effect profile was very reassuring. And again, this effect on lung function most likely is due to the blockage of downstream signal of the interleukin 13. Now, what about oral steroid dependence patients? In this large study called SOURCE, tezepelumab did improve or reduce oral steroid need only in patients with high T2 signal, high blood eosinophil at baseline, either more than 150 or more than 300. But in the general asthma population, it failed to reduce oral steroid need. A large trial now is ongoing to test this further. So I mentioned that comorbidities are important in the selection of biologic. How is that? Well, I showed you that some of these biologics are approved in certain comorbidities, and these may help you decide which one to choose if these comorbidities exist. Most important are the nasal polyposis. There are 3 biologic approved for nasal polyps: dupilumab, mepolizumab, and omalizumab. Dupilumab is also approved for atopic dermatitis. There are multiple studies ongoing to look at these biologic in COPD, for example, and in some other diseases such as ABPA, and also and as well as in asthma COPD overlap. These data are not yet there. So, but what you see in orange are the indicated comorbidities for these agents. What about safety? What can I know about them? In general, these biologics are fairly safe. Hypersensitivity at the site of injection should be the most common side effects you will see. 2 of them have black box warning of anaphylaxis, although these are very rare, but patients should be educated on this. Like omalizumab and reslizumab have black box of anaphylaxis with their use based on these clinical trials. There are some cases of increased herpes zoster with mepolizumab. It's suggested that patients who are above 50 should get herpes zoster vaccine. With omalizumab, because of the anaphylaxis, it's suggested that they get epinephrine injections to carry with them. In general, the risk of helminthic infection is low, but if given in areas where there's increased risk of parasitic infection, one has to be cognitive that blocking eosinophils may increase risk, but this has not been shown to be an issue, at least not in the North Americans. So the question is, how we surveyed physicians, as Dr. Panettiere mentioned, and about the patients, what they perceived the patients thought about biologic, and this was the question we posed. Among your patients with moderate severe asthma who are currently treated with a biologic, what would you say is their level of satisfaction? And you can see that the majority said moderately satisfied, which actually was pretty good for me. In my mind, I think I would have said somewhat satisfied. So I see patients who get really much benefit from biologic. Others, they have moderate benefit. But we'll talk about how long to treat before you jump into a conclusion that this is not working. That's very important. And then what are the barriers? And these are important because the barriers that we face in prescribing biologic may not just be based on the patient, but also based on the drug, but based on insurance. And you can see that there's lots of need for education in this area. In fact, 33% of respondents said that they wanted to know more about this so that they be more in tune of what are biologics, how do we prescribe them, how do we pick which one to use. There are some barriers, obviously, that we cannot say that it is a slam dunk. Prescribing biologics can face some barriers. It's actually a big commitment for the patient as well. And so patient education is very important. But also, picking the biologic is not an easy task. One has to really take a good, do a good homework before deciding on a biologic. But if you decide the patient needs a biologic, you have to really assess several things and address several things with the patients. These are shown on this slide. You look at the patient profile, the phenotype, the biomarker profile. Do I really need to go there, or can I treat the patient with just existing therapy? And when it comes to a decision that yes, we do, then you sit down with the patient, look at the options, consider cost, insurance covers, patient's preference. There's quite a bit of overlap when you choose a biologic. More than one biologic may work for a certain patient. And so sometimes you'll have to do a prioritization, address patients' concerns. These are some of the concerns the patients have, regarding treatment. How safe is this drug? How long am I going to take it? Is it going to cost me a lot? How safe is it? All these things should be addressed, and having a shared decision making with the patient is really very, very helpful. But also patients should know that, biologic will not replace their controller therapy. They also should know that it's not just a one shot, that it's going to be at least 3 months of treatment to see if they respond, and then decide if you continue or stop or switch. These are very important. There are several algorithms that help us as clinicians pick which biologic to use. The GNAD in the latest iteration suggested that we look at the patient phenotype, the history of exacerbation. Obviously, in patients with allergic asthma, anti-IgE is still a beneficial biologic here. In patients with eosinophilic asthma, whether they are oral steroid or not, anti-IL-5 agents is a very good choice. In patients with T2 high asthma, high blood eosinophil or high pheno, oral steroid-dependent asthma, anti-IL-4 or dupilumab is a good choice. And then anti-TSLP or tezepelumab may be a good choice in general, severe asthma patients. And again, it's one of the newest agents that have been approved. In all these, there are clinical trials to show that there are some patients that may behave or respond better depending on their biomarker profile. So measuring biomarkers may actually give you an idea who would respond best to which biologic. And then there are certain algorithms that have been published. This is one that was recently published in a New England paper that looked at two things that we would look at. One is whether the patient is on oral steroid or not, and then go down and look at their blood eosinophil levels. And as you see, in patients with oral steroid, if they are eosinophilic, then you may have more than one options. If they don't have high eosinophil, then the only option is anti-IL-4 or dupilumab. And then, of course, tapering oral steroid is important. In patients who are not on oral steroids, you look at blood eosinophil level. patients with low blood eosinophil and high FeNO, the options here is an anti-IgE or dupilumab or anti-TSLP. Those patients with low FeNO, low blood eosinophil, but only allergic, anti-IgE or anti-TSLP may be an option. More important is, again, be patient. Once the patient is started on biologic, one has to address several things. How do I assess? How do I know a patient is improving? The trial of 3 to 6 months is really imperative before you start switching or stopping. You look at several things. We look at patient's response, how they feel about it, the quality of life. Was I able to reduce oral corticosteroid? Are the symptoms improved? Is the lung function better? Some of the biologics are shared with a big change in lung function. So all these things are important to address to assess response. It's not just the one thing. Now, some patients may not respond as well. You really need to address, is it medication related? Is it the phenotype that I didn't do a right job in phenotyping these patients? So you may repeat the biomarker profile checking on them. Or is it the patient that has a different phenotype that I need to address a different biologic? And switching biologic is something that we try not to do, but we have done it in patients who don't respond to one agent. So let's just go over applying the evidence. I have a couple of cases I want to share with you, and then I'll ask Dr. Panettiere to present one more case, and hopefully we'll have time for some questions. So how do we put all this together? Well, we know that our thinking about severe asthma has changed. We now know that it has multiple phenotypes and phenotypes. It's no longer one size fits all. And even when it comes to moderate severe asthma, there are options. And so it really all starts with the patient's story. So, for example, this is the first case, Mary, who comes to us with asthma. She's 41. She was diagnosed at age 30, so she had asthma that is late onset, has chronic rhinosinusitis with nasal polyps. She's currently on high-dose inhaled steroid and LABA. She has history of exacerbation, treated with oral steroid, quite a bit, 3 of them last year. And she's uncontrolled, as you see from her ACT score. That's why ACT score is very important to measure. And then her biomarker profile shows significant eosinophilia, a very high FeNO, and total IgE is actually low. So she's not an allergic patient, but she definitely has T2 high asthma based on high FeNO and high blood eosinophils. And also she has low lung function, 73% for a 41-year-old who is a non-smoker. That's sheer low lung function. So the way to formulate it, one, obviously, you have to go through the checklist. Is this asthma, which most likely it is? We have the spirometry. Am I addressing all the comorbidities? The chronic rhinosinusitis and nasal polyp is one to look for. Of course, we ask her about sleep apnea. We ask her about GERD. But all these are very important. They go hand in hand in your head. And then also check on the adherence and can she use her inhaler correctly? Is she using her inhaled steroid? The main goal is to reduce exacerbation, minimize need for oral steroid over time. We can always try to escalate therapy, but she's already on high-dose inhaled corticosteroid. So this is the type of patient where biologic may be a good choice. And you look at comorbidities, she has nasal polyposis and high eosinophils and also high FeNO. There are options here, and then you go from there. So this is how we sort of get to decide on a biologic in a stepwise fashion. The next patient is more dramatic. He's 25-year-old who's diagnosed asthma, also late onset, also on high-dose inhaled steroid. But this is a patient who's oral steroid dependent. And I kid you not, these patients are the highest risk because they're dependent on oral steroid. He's 25-year-old. I've had patients who've had hip replacement at 28 and 29. Unfortunately, oral steroids are really should be avoided on a long-term basis. Even as low as 5 milligrams a day carries lots of risk of comorbidities. This patient continues to have exacerbation. His eosinophil count is not high, but remember he's on oral steroids, so eosinophils may be tapered down with oral steroid. He does have high IgE, and FeNO is borderline, and he has definitely oral significant airway obstruction. So this is a patient who is oral steroid dependent. He is allergic. He has allergic asthma, and he is still exacerbating. And obviously, the choice here are limited with oral steroid-dependent asthma. We'll talk about that in a minute. But oral steroids are not a good thing to be on. And in fact, unfortunately, when you look at data from the United States and even our survey, as you saw, 30 to 40% of patients with severe asthma require long-term oral steroid to improve asthma control. And some of them actually may need repeated short-term courses of oral steroids. Others are on long-term oral steroid on a continuous basis, and we know side effects from oral steroids are quite a bit, and these are things that we need to avoid at least or address in patients who are oral steroid dependent. So the key for this patient is to, first of all, verify adherence and correct inhaler use, attempt to minimize the oral steroid over time, but then also try to escalate biologic in patients who are dependent on oral steroids. There are several options here, as you mentioned. Mepolizumab have been approved for eosinophilic oral steroid-dependent patients. Dupilumab is approved for all oral steroid-dependent patients, whether they have high eosinophilia or not. And there are several clinical trials that I showed you earlier. So with that, I'm going to transition to Dr. Panettiere. He has one more case, and then we'll hopefully have time for some questions and answers.
Well, Dr. Hanania, that was an amazing a tour de force, and I appreciate the wonderful insight. So case 3 is a 7-year-old boy with asthma on high-dose ICS LAVA. He was a full-term baby. He has had 3 exacerbations, 3 in the past year. 2 of these occurred in the fall. His maintenance therapy is ICS LAVA and Montelukast. His serum IgE is 200, his blood EOs 150, and he's markedly positive RAS to seasonal allergens and house dust mite. So what monoclonal antibody would you choose? So well, let's take a moment here. What endotype does he have? Well, is he high T2? You betcha. Is he eosinophilic? Not so much, but he is high T2 allergic, and that's what you see mostly in children. So he was started on omalizumab. It's clearly indicated to that age. He received 6 months of therapy. Despite the therapy, the patient had 2 exacerbations. 1 required hospitalization for 3 days. Inhaler technique was assessed and determined to be adequate. Evaluation of pharmacy records showed the patient to be adherent. So what is your next therapeutic option? Well, these are challenging. It's a challenging case because he's clearly failed traditional anti-IgE therapy in an atopic. So the concern there would be the use of another high T2 antibody that would be approved for use. So again, here, not all monoclonal antibodies work in this space. So with that, I want to stop the formal presentation and move on to Q&A. Nick, I'm sure you're game for some questions here. So let's open this up, take a look at the questions, and happy to take any that some may have.
There are 3 questions I see, Ray.
Oh yes, all right. So why don't we take the first one? You take the first one, Nick. What are the essential elements of an asthma action plan?
Well, in general, the action plan is usually based on peak flow measurement that has been traditionally used. You can have an action plan that is just based on symptoms. And we usually try to educate the patient on tagging on the number of rescue medication they use, their peak flow. Usually, if they know their best peak flow we use the traffic signal technique, the green, yellow, and red. So if they're less than 50% of their best peak flow, then they're in the red. If they're above 80, they're in the green. And basically, we use it for patients to try to educate them when to call for help, when to go to the emergency room, and when they continue doing what they're doing. And again, it's something that Gina has really emphasized on. Most NIH asthma guidelines emphasized on. Written action plan is preferred than just the verbal one. So they need to know what their medications are, why they're taking them, what are the rescue medications, what if you're using a peak flow, what's the cutoffs, and what to do if they get in trouble.
Excellent, excellent. There's two questions here. I'm going to bundle them, and I'll take this one. What is the best biomarker for monitoring response to a biologic in patients with moderate to severe asthma? And what biomarkers indicate a good response to an anti-IL-4 drug? Well, biomarkers are very valuable, not only to show activity of disease, but engagement of the therapeutic target. So if we think about pharmacodynamics, that's when the target has been affected by the drug. The one that I think of for anti-IL-5s is the peripheral eosinophil count. The peripheral eosinophil count should go down remarkably in the presence of an anti-IL-5. That tells you the target was engaged. Now, does that mean the patient will do better? Well, that's up to you using an asthma control test or patient-reported outcome measure, as well as spirometry or the ability to taper steroids. But at least with an anti-IL-5, the eosinophils should go down. If they don't go down, then that's quite strange. Or if they've not gone down to a certain threshold to affect the disease, or they're independent of the disease, then the therapeutic response will not be optimal. So what biomarkers are anti-IL-4 biologics? Well, there it's going to be FeNO, right? The fractional exhaled NO should go down in the presence of an anti-IL-4 target. So that again shows target engagement, and it should track with the ability to improve outcomes in asthma. Hey, Nick, I have another one here that you might be interested in. Have clinical trials showed efficacy of biologics for moderate severe asthma improve comorbidities such as atopic derm, chronic rhinosinusitis with polyps, or allergic rhinitis?
Yes, actually, as I mentioned in my talk, several of these biologics are approved for comorbidities, and indeed, several of these asthma clinical trials, as you know, in patients with asthma often have other comorbidities, and they're enrolled in clinical trials. For example, with dupilumab, there's been significant effect on the nasal symptoms, sinusitis, but also looking at the quality of life with the sniff, looking at SNOT 22, which is a quality of life for nasal patients with nasal polyps. But the polyp size also has been looked at as well. Similarly, with atopic dermatitis, dupilumab has been shown to be very efficacious in patients with asthma who have atopic dermatitis, but certainly with atopic dermatitis alone. I think the more we study these biologics, the three of them are approved now for polyposis, omalizumab, mepolizumab, and dupilumab. One is approved for atopic dermatitis, and I think the concomitant comorbidities may help us select if these comorbidities are there, may make your decision easier which biologic to choose.
Great. There's a question here I'll take is, are any JAK inhibitors under study for asthma management? The answer is yes. In the PRECISE consortium, this is an adaptive design approach funded by NIH. JAK inhibitors are under investigation there. Remember, JAK-STAT is an amplifying molecule downstream from IL-4, IL-13 receptors. So the concept makes sense. Biologic plausibility of taking out JAK and amplifying signaling molecules should have an effect. We should hear more of that. And at that point, I think we're 1 minute away. So I want to thank my colleague, Dr. Hananea, and thanks to our audience for the great questions. I would also like to thank Regeneron Pharmaceuticals and Sanofi for their support of this important educational activity. Please remember, hey, this is really important. Please remember to complete the post-test at the end of the session to secure your continuing medical education credits. Please visit Immunology Live and resinsightslive.com to view today's session, along with other sessions on demand. My name is Dr. Reynold Panettiere. I want to thank you all and wish you the very best and safe day today